Hi, this is Walt Medlin in Salt Lake City, Utah. I will have my email also in the last slide as well, but definitely I'm hoping to have a dialogue with people coming out of this talk and other talks in the conference. I'm really excited to be a part of this panel, and I thank SAGES for the opportunity here. I am sad that we won't probably have an actual panel because the other speakers, I'm really excited to see their talks, and I'll try not to cross over too much. I'll try to stick to my focus, which is that the loop duodenal switch, or the single anastomosis duodenal ileostomy, is the best option for weight regain after sleeve gastrectomy. I have a disclosure slide here, and we're just going to, this video should play through the course of my talk. I don't have any financial disclosures. I'm sorry, I don't have the actual SAGES slide up for this, but I'm actually recording in Keynote rather than PowerPoint. Personally, though, I'm one of the two surgeons on the panel who is a weight loss surgery patient, and I actually had a sleeve gastrectomy originally in 2008 at a peak weight of about 300 pounds, managed medically and lifestyle to about 280, but really couldn't lose more than that without regaining almost immediately. And sleeve really saved my life. I had severe hypertension at that point, and it was wonderful. I lost to about a stable weight of about just under 210 pounds and was doing great for 12 years until 11 years until, lo and behold, last summer I had a heart attack. And it turns out I have aneurysmal disease in my coronaries, and that is just critical to have maximal blood pressure control. So even though my weight was reasonable, it was certainly not ideal. We'll talk about that a little bit. I was on 3 meds to get to optimal control at age 55. And because I knew that some additional weight loss would be better, blood pressure control, I underwent revision to single anastomosis duodenal ileostomy. This is not my surgery. This is a robotic operation, but same deal. This is used with permission of the patient. You can see making incisions here. This is an 8X, so it's probably going to finish pretty quickly. It may replay. But basically, you can see we're just dissecting out the duodenal bulb and then forming a back row, and then basically creating a 2-layer posterior, single-layer anterior anastomosis. So that's what I had done in December, and I had it done for the same reasons that most patients have revision surgeries done when they are well informed in terms of my choices. So let's talk about the framing of the question. And I think this again fits into the bigger part of the conference or of the panel, which is the overall focus of weight alone in bariatric surgery. I think quality of life really is the key driver for most people. However, we do tend to get lost when we're sort of choosing a model in what's going to give you the best weight loss. I think surgeons have to be incredibly patient and resistant to letting that be the only driver. And so even though I'm speaking about the operation that I think is the strongest weight loss of the operations that we mostly do, the full DS with the Roux-en-Y is maybe a little bit stronger, arguably, but not by much. But I don't advocate for loop DS just because it's the biggest weight loss bang for the buck. It really is, I think, something that goes beyond that. So again, reframing the question of revision, if we only focus as surgeons on weight, then we are going to be really limiting ourselves. And we also have to recognize, if we're doing revision surgery, that there's a wide variation in patient factors that drive even what we think is simple behavior. There are a lot of drivers. Certainly genetics is probably the single biggest cause, but we don't have good measures of that. We really can do a good job of identifying patient airway test at the end. Sorry, that played super fast. It may play again. Medications we're starting to recognize can really drive weight regain, especially some of the psych meds and beta blockers and other meds, but then disease processes like untreated sleep apnea, and certainly diabetes can drive regain. And then I put under just general stress, but there's a lot of environmental factors that can predispose to regain also. Now, these things need to be looked at and addressed, but I also think that even if several of them are present, that does not preclude a patient having an operation. They just need to be addressed alongside proceeding to an operation. So I don't want behavior to be used to eliminate the possibility of revision for a patient. As Dr. Higo once said, our job is to prepare patients, not to judge them or to disqualify them. So I think, though, that the other side of that equation comes in too, of patients often have an expectation, well, my previous operation fixed everything and I was great for X number of years, and I just need a bigger operation. I just need a bigger gun, I need the magic back, the honeymoon. And so this chronic disease management model really is critical. And even though surgeons probably aren't the ones delivering that care, we lead it and we coordinate it, or we can lead it. Certainly we can at least lead the patient to that care. So if we are always focusing on pounds on the scale, then we will ultimately be judged downstream by the patient that way too, if they only cared about the pounds on the scale. And so I think we really need to listen and explore all these options with the patient and form a partnership. And so that's reframing. So there's the illustration in the left upper of just basically what we're doing. We're basically just counting back 250 to 350 centimeters on average from the ileocecal valve and creating an anastomosis with that 1 centimeter of duodenal bulb that is left behind after we divide it. Let's see if this video will play again. I think so. I'm going to play it again just if you're watching in the background. Okay, so I'm not going to put a lot of data into this because I want to have a couple of pieces you can take away. There is a lot of study out there, particularly about the success rate of duodenal switch and SADI, especially from Spain, and that's how I originally got interested in it, seeing it presented at a conference not long after I had my sleeve. I was very interested in, as are many patients, what happens if this doesn't work for me long term? And I was just blown away by the data out of Spain. My friend and now my partner Dan Cottam actually did what he usually does and really got out ahead of this, called people, talked to people, put things together, and actually started doing these in a study. And then a couple of years later, I actually joined him in practice. He had trained me in Phil Shower's program in Pittsburgh, and that's where I first learned about staging and sleeve gastrectomy when Dr. Shower was still at UPMC. I was a mini fellow, then Dan was a full fellow. So, however, this is where I want to take a step back and not over-rely on the data. I think most of it is really only weight focused, and it's often excess body weight rather than total body weight, which can be really misleading, as better statisticians have taught us, but I do think they're still useful. The starting points also are pretty ill-defined in a lot of studies of, was this the weight at operation? Initially, was it the weight at reoperation? What was the highest weight? But I do think it's still good to be able to give patients a general idea. We talked about chronic disease management. I also think talking about responders, super responders, partial responders is a good language to get in as well, so that people don't feel like they have failed if they do not achieve the average weight loss that we see because of all these factors. And I think, again, this language starts with the surgeon to lead the program in terms of objectives, to not be overwhelmed by weight loss that's not as much as expected. And then a lot of our data, a lot of the studies with respect to, especially I think some of the medication studies and minimally invasive studies, they're excellent outcomes, but they're often short-term. And I don't think that means they're not useful. I just think we need to have that discussion. with the patient as well, so they don't feel disappointed if it's a shorter term response. They still may choose that. So here's the takeaway data from our study is that when we staged patients in a multi-center study, 2 groups in North Carolina, 1 in California and ours in Utah, whether they were planned staged, so those tended to be our super obese patients or our patients who were extremely ill and just couldn't tolerate the slightly longer operation or bigger operation. You can see in the line that plateaus early. They came back to surgery relatively quickly. They ended up attaining basically the same weight loss. And again, this is EWL, but it still works in general for the group. These were patients in the super obese category mostly. And then the other group of patients had regain, and that's where the red line goes down. That's regain. When they were modified to loop duodenal switch, they basically achieved the same weight loss that we would expect if they had started with duodenal switch, or the same as the group that had a planned reintervention. Personally, I actually think this is useful for some people as well, because it gives us a chance to have more intervention with them as a program. We all know that patients do have a tendency to stop seeing the value of repeated office visits, and if they're coming back in and re-engaging with the dietitian, re-engaging with the program, that can be really helpful. So here's the takeaway that I tell patients. The average total body weight loss. It's doc, how much can I lose? Depending where they're starting from, it's going to be 30 to 40% total body weight loss from their peak weight ever, on average. Doesn't mean some people don't get better, some people get worse, but I think quality of life, if we focus on that, they're not going to be unhappy. The average is an additional 20% for patients who are upgrading or changing. I use the word upgrade a lot, from sleeve to SADI. But still, overall, the same responses if one state. So they don't feel like they've blown their opportunity. And also, when patients are choosing sleeve, they don't feel like they're losing an opportunity. The main thing here with the data, this is what I feel like we're not focusing on enough, is most patients really are focused on safety. That's why they had a sleeve in the first place. And the safety profile of loop duodenal switch is far superior to Roux-en-Y gastric bypass. And we know that diabetes resolution and weight loss is at least equivalent and probably better. So the safety profile, I think, is more important data. All right, so what are the barriers? Training surgeons is probably the main barrier. If this was already in your armamentarium, you would probably be doing it really with almost no additional data. There's enough data. Insurance chaos is a bit of a barrier, but I'll tell you, there really are easy ways around this in terms of coding it simply as what it is, which is a small bowel division and anastomosis, or coding it as a duodenal switch with a reduced services modifier. In some companies, it depends on what they want. Sometimes they don't want that. And then the other barrier is patient misconceptions, both for and against. I've had patients who inappropriately wanted loop duodenal switch because they thought it was the best, and they were focused only on the weight and not their safety, and certainly not some of the side effects with gas and stool changes. But then there's other people who think it's too big an operation. That's why I'm very glad to be able to stage for them and say, you're not burning any bridges with a sleeve. So the takeaway, let's see if I can get that to play. Come on out and see us in Salt Lake when you're allowed to travel. We won't throw you off the side of a mountain, but you can go hiking. SADI should be an option for any program. And in the COVID age, there's really good instruction on YouTube. I will encourage you to try that. Please contact me. And thank you very much for the opportunity to speak. And I hope this was useful. Thank you so much.